So moving on to brain abscess, another one in the condition series. So the way to think about brain abscess is the same as any space-occupying lesion with the added element of infection. So a brain abscess is a collection of pus. It's an infected region, and it's a space-occupying lesion within the brain, so it will cause symptoms depending on whereabouts in the brain it is. So bacterial abscess can be seeded from distant sites, okay? So infected emboli can spread, so the one we always think about is infective endocarditis, so you need to look for signs of that. Suppurative lung disease, so if people have lung abscesses or emphysema with complications, or a right to left shunt due to an abnormal circulatory system. Or there can be local extension. So in terms of a cerebral abscess, we think about chronic infection of the sinus, of the inner ear. That tends to be much more common if people have had extensive ENT or facial surgery, or in the context of things like poorly controlled diabetes, where folks are more prone to infection. So an abscess is an area of necrosis and inflammation surrounded by a membrane or a bubble, if you like. So if somebody has a hemiparesis, then you might think about the abscess being in somebody's motor strip. If somebody has altered behaviour, you might think about the abscess being in the frontal lobe, but you would also see fever and seizures associated with that. There are exclusion criteria for why you would do a lumbar puncture in somebody without prior imaging, and this is why. So if somebody has meningitic features, but they also have a hemiparesis and fever, you know, the reason for this is they could have an abscess, and that's why we image somebody if they have focal features before doing a lumbar puncture. The risk is that somebody with high intracranial pressure has a risk of coning and death. So focal neurological features, and that includes things like seizures, altered behaviour, and abnormal fundoscopy, they must have imaging done before a lumbar puncture. So investigation and treatment. So we obviously need to image if we suspect an abscess. The fastest way to do this is a CT, but contrast is very helpful if you suspect an abscess. MR obviously gives much more detail, but patients have to be more stable, less sick to get through a longer scan. We would see a round, discrete lesion. It's got a thick enhancing ring, which is the membrane around the abscess, and surrounding edema or swelling. So it's a very irritating lesion, so the brain around becomes very swollen. The treatment is using antibiotics and surgical drainage and antibiotic treatment guided by the cultures. So early blood cultures are needed, but surgical cultures from the abscess itself after drainage are much more likely to give accurate results. And the survival and how damaged somebody is afterwards depends on the size of the abscess, the location, how quickly they're able to access treatment, and the response to intervention. So obviously if you have extensive abscesses, delayed treatment, very resistant bacterium, then people won't do as well than if somebody has a very small abscess in a non-eloquent area, so an area of the brain which tends to give less deficits. Weakness and seizure susceptibility, even after good treatment for abscess, is pretty common. And I just have a couple of pictures for you here. So this is CT imaging of somebody who had a depressed skull fracture, which subsequently then developed into an abscess of the frontal lobe on the left side, and that's because there was direct extension of infection from the skull fracture.